Chances are that you know someone personally who's undergone hernia repair surgery. After all, this is one of the most common surgical procedures in the world. And when most people think about that procedure, they conjure images of an unsightly plastic mesh that's sewn into the body, and they might even think about all the potential complications that can come from having a foreign object sewn up inside of them. But as it turns out, hernia repair is not a situation where one size fits all. And there are quite a few different proven solutions for dealing with these types of problems. And some of those solutions involve no mesh whatsoever, and they use only your biological tissues. Now, these techniques are minimally invasive, and they have an outstanding success rate. So this week, I brought in an expert with over 3 decades of clinical experience to talk about why hernia is such a common problem and what are the best ways for dealing with it. Let's get into this. Welcome everyone. We have a special guest today. Dr. Jonathan Yunis is a minimally invasive abdominal wall surgery specialist. He's been in practice for 33 years, and in that time, believe it or not, he has performed over 15,000 surgeries. So he's making the time for us today, taking a break from surgery. Thank you so much for being here, Dr. Yunis.
Thank you for having me. Really a pleasure. Thank you.
This is so awesome. So in preparing for our talk, I read a study that was published in 2018 that said that there are over 20 million surgical corrections for hernias every single year worldwide. So you gotta tell me what is going on that we need 20 million hernia repairs every single year.
Right. Yes, it sounds like quite a few. There's many different types of hernias, and they're actually not that common. There's types that are genetic that we're born with the potential for, what we call primary hernias, and then there's a whole nother world of hernias that people get that are incisional hernias related to abdominal surgeries, where the scar that was made to go through the abdominal wall doesn't heal perfectly, and there's very unusual, complicated hernias that can occur there as well. But there are 8 billion people, so that is still, it is not as common as, say, cataracts or other human conditions, but certainly it is pretty common. Yes.
So you're talking there about the various varieties of surgeries. What are the most common types, or what do you see most often in your practice?
Well, I personally have a very tertiary practice where I fix a lot of complications from hernia surgery. But the most common type of hernia is primary hernias that you have a born potential with, like in your belly button. We call them umbilical hernias. Are there other parts of the midline, like between your two rectus six-pack muscles, things called epigastric hernias? And then inguinal and femoral hernias occur in the groin, in the very lowest part of the abdomen, in the top of the pelvis, kind of where the torso meets the legs. The very bottom, if you look at the anatomy, there are 3 oblique muscles and 2 rectus muscles, and they kind of wind back down where it meets the pelvis. And there's potential weak spots there that have potentials where they overlap, where there could be a hole that could form. So inguinal and femoral hernias are the other most common. Inguinal, femoral, umbilical, epigastric, those would be the most common, yes.
Okay, so the umbilical hernias are something that we're generally seeing in infants, is that correct?
They actually present at any age, but certainly infants very commonly get them. And it's one of the interesting thing about infants and their umbilical hernias, right? And to be clear, the umbilical hernia is where you are connected to your mother through the umbilical cord, of course. And it's a potential, if you think about it, weak spot, because it connects the embryo to the outside world through a cord. With many structures going through it, and as the time you're born, it's supposed to close up. So many infants are born with a small opening there where there's a protrusion through the skin, and this is the only type of hernia really that will go away on its own, which is what's unique about that. So yeah, many infants are born with it; they tend to go away, but adults of all ages can suddenly present with a new umbilical hernia. Yes.
Wow, and what is the origin of a problem like that?
It's still a genetic predisposition, which could be confounded with environmental influences like heavy lifting or gaining a lot of abdominal weight, so other forms of pressure against the wall. But I think you need to have some genetic predisposition to develop the umbilical hernia. Even when it presents at an older age, it's just less of a genetic penetrance of the gene versus a infant being born with the hernia.
Okay, so you talked there about genetic influences, and in our previous conversation, we had talked about that as well. And that is a main factor, it seems like, in the development of any type of hernia. Now, I was reading about some of the internal and external risk factors. One of the ones that made total sense was the presence of like a connective tissue disorder like EDS.
Right. That's right.
Which makes perfect sense, because if the tissue that's supposed to retain everything is weakened, then it makes sense that it could spill out. The other thing that was mentioned is what you just talked about there, which is the being overweight or obese, and that increase in intra-abdominal pressure that goes with it. Again, you're straining against the abdominal wall, so it would make sense that that could lead to a rupture. The other thing that I found that was really interesting was tobacco use.
Yeah.
So
right, that may have some effect on a cellular level. We don't really know completely, or possibly from its effect on the lungs with coughing and increasing intra-abdominal pressure that way.
Oh, yes, the chronic coughing. And there was some debate, it seemed like, on people who suffered with chronic constipation and the constant straining that goes along with that.
Exactly. Another factor, absolutely, that would contribute to the development of one, but underlying all of these primary hernias, not surgically induced, is a genetic propensity to get the hernia. Yes.
And I would love for you to repeat what we had talked about off camera, which is the question that I asked, like, who are the populations that you're seeing this in? So we know that there's the overweight and obese, but in one of the studies that I read, the age range, Dr. Yunis, was absolutely massive. It was like age 18 all the way up to 86. And so you're like hyper athletic, super fit people, and then you've got overweight people. The one thing that seemed to be a big risk factor for the inguinal hernias was being male. And then they seem to go with older age.
Correct. Yes. The types of the range that we see, exactly you say, is from birth till 100 years old of the development of hernias. And again, the strong genetic penetrance in an infant will present with an inguinal hernia at birth. So it's the most common operation performed by pediatric surgeons is repair of inguinal hernias and sometimes umbilical hernias, these primary hernias. So that's a common thing. I personally don't fix those at this point because that's a big overlap with the pediatric surgeons. But then there's another big peak, as you mentioned, of people, in their 20s and 30s and 40s, and that has nothing to do with necessarily obesity at all. Very strong, in shape people get it, and it's just maybe the varying degree that they push their bodies makes it present at a certain time. Again, as long as they have this gene that potentially they inherited from their family, that they'll get this type of hernia. And then we see a very big peak in people in the 60s. And then another one in, it sounds like it could be any age, but there really are these peaks in population. And then another one in the 90s. So I treat all different kinds of people. We customize it depending on who that person is. There's many different hernia operations to optimize the outcome for different types of people that get hernias.
That's one thing that I would love for you to just shed a little bit of light on. So you mentioned briefly there the epigastric hernia and the separation of the abdominal blocks, if you will.
Yeah.
Can you tell me, because I don't know what the difference is between an epigastric hernia and a diastasis recti?
That's a great question. The diastasis recti, people are very familiar with, which is that comes often when women have had multiple pregnancies. Men can just get it genetically or with weight gain. And what it really represents is when you imagine you're young and you're strong and you have a 6-pack or an 8-pack and your rectus muscles are attached directly to your chest. all the way down to your pubis,
Mhm.
and those muscles are right next to each other. And there's about maybe a centimeter and a half between those muscles.
Mhm.
And between the two rectus six-pack muscles is something called the linea alba,
Mhm.
which is like a tendon in other parts of the body. Like it's like the central tendon of the abdomen.
Mhm.
And this linea is a mesh of fibers that embryologically they emanate from the oblique muscles passing over the rectus muscle. This is actually becomes very important. And then between those two muscles, on a microscopic level, there you can see this weave of these fibers between the muscles, and with stretching over time, like with pregnancy to expand the abdomen,
Mhm.
or gaining male intra-abdominal weight, those muscles can spread, and that linea alba widens sometimes to 7 centimeters when normal would be 1.
Wow.
So these are not dangerous types of problems, but often cosmetically deforming, and sometimes they cause discomfort. It's very an area of controversy, but we fix a lot of them in conjunction with hernias or on their own.
Mhm.
But to get to your question, an epigastric hernia forms in that same linea alba midline location, and it's a true hole
Okay.
through these decussation of fibers, like between the weave. All of a sudden, one of those tiny little less than 1 millimeter spots of the weave, half a millimeter, over time starts to open, and internal fat, usually the special kind of fat that lives behind, just starts pushing out. So these are rarely dangerous hernias, epigastric hernias, and but they can cause discomfort or cosmetic deformity. And they occur more commonly in women, and they happen very often in thin, muscular people. And also, I believe, a genetic predisposition. And then it can occur anywhere from the xiphoid, right under the chest, to the umbilicus, to the belly button.
Mhm.
So there are two very different things, yeah, but they occur in the same place.
Interesting. So you mentioned that the weave there, you can almost think of it like cloth fibers that are overlapping, and the fibers run in different directions.
Correct. Yes.
And so all you need is one little fiber missing from that cross,
Right.
and you can have
Right.
tissue escape into that region.
Absolutely. Yeah.
Very interesting. Now you keep mentioning the genetic predisposition. Has there been an actual gene that's been identified that goes with this?
It's being worked on. We don't know enough about it.
Mhm.
There's something in a cellular level about different types of collagen, the
Mhm.
protein used as a building block, for tissue,
Mhm.
that we think that, there may be some change in that about why some people get hernias, but it's not something that we can test for right now.
Okay.
But so that's a great question. But the interesting thing about that is hernias are not as commonly dangerous as other genetic problems,
I see.
like cancers related to genetics, or coronary artery disease.
Mhm.
So in fact, there's some speculation on an epidemiological level that people that are hernia formers genetically may actually even have a lower risk of malignancy. Now, this is not proven,
Mhm.
but what we look at, it's almost like an opposite type of thing in terms of the collagen, and what happens. So the genetic, so there's not that much of a need to identify that right now, because it's
So
not
not as much money
save
is being
lives.
is that I understood. So they're just not
Yeah.
putting as much money towards it because it's not a
Right.
life-threatening condition.
Right. So what, there's not, either way, you're just going to fix the hernia or live with it.
And because the surgical success rates are so high, it's like we already
Right.
got this type of thing.
Right. Exactly.
Interesting. I'm super curious if there's a link because of that connective tissue disorder, if there's a link between people who require hernias and hypermobility in general, because you do see those people with that different collagen makeup, and they might have a type that tends to be more forgiving or
Yeah.
less rigid. And so you have situations like this where I can touch my thumb all the way to my wrist. And so I don't have EDS, but I'm definitely on that spectrum where that collagen is a little bit
Right.
more pliable.
I think that's a great point. I think I see that, but it's not well defined. Very,
Okay.
yeah,
That would be an interesting diagnostic. And speaking of diagnostics, just because a person has pain in their abdominal wall or at the crease where the hip meets the pelvis, it doesn't necessarily mean that it's a hernia. So what are
correct.
some of the prime diagnostics, like clinically, without the use of imaging studies for identifying a hernia? How would somebody know that they have one?
Yes, yes, that's a great question. Basically, I see a lot of people that have groin pain, we would call it,
Okay.
pain in the area of the inguinal canal, like you mentioned, where the abdomen, pelvis meets the leg.
Mhm.
And pain in that area can be caused by many different things, and it can be very hard to figure out. So
Mhm.
for hernias, the thing that would be obvious is that you have pain in that area or discomfort in that area, and you see a bulge, like literally, you stand up or you cough, and you see something kind of pushing outward under the skin. And when you lay down, it goes back in. And that classically defines a hernia. But there are many people that it's very difficult to figure out whether they have a hernia or not, and they don't have a visible bulge, but that's the source of their discomfort.
Mhm.
So we have to, do other things, outside of imaging. The other thing would be, when someone's pain is very much related to like hip rotation or flexion,
Mhm.
depending on what age they are or other comorbidities, that we think that this can have a big overlap with hip arthritis and
Mhm.
other hip joint things. So even though we call our hip visually the side of your where your hip is externally,
Mhm.
the hip joint where the femur meets the acetabulum of the pelvis causes pain often right in the groin, right where hernias are. So there's a lot of confusion there.
Mhm.
Um, and hernia, and many people have hernias, and there is no discomfort or pain. Many inguinal hernias are painless, actually.
Mhm. Interesting.
So then we have our imaging, CAT scan, ultrasound, MRI that we use for different things for it.
And the bulge that you're talking about that a person would see with a hernia, what size would they be looking for? Is it a fist size? Is it a silver dollar?
They, it varies from just a slight bulging, general contour bulging out to very focal, golf ball sized,
Mhm.
so it all depends, but if you see anything
Mhm.
that's different, that moves, that's usually a hernia,
Okay.
that,
So
that's
it's
not
like a that shouldn't be there type of
right.
thing.
Correct. That's
Okay.
right. That's right.
And regarding the pain pattern, I understand that there's quite a wide variety up to and including completely painless hernias. But what would be the textbook pain pattern?
It's a burning pain is really what's very consistent. I've never had a hernia, but I hear this from people. You can just see it. They go, yeah, it's like a hot knife. Someone's poking me with a poker,
Mhm.
a searing discomfort. But then other people say it's sharp, and it occurs with, strenuous activity
Mhm.
or prolonged sitting, but there's a lot of overlap in the description of the symptoms that could be other orthopedic related problems.
Sure.
So yeah,
What makes this, what relieves the symptoms?
usually laying down,
Hmm. Yeah.
and that allows gravity to bring what's coming out of the hernia back inside
Yeah.
of the
Yeah.
patient.
Yeah. And then I think the one thing that I always saw in clinical practice with people with a hernia was lying down relieved the problem, like you just said. But then as soon as the act of lying down was very painful, and then trying to get up was very painful.
Right, right.
So that increase in abdominal pressure when you're trying to brace to move triggered the symptoms. And then, yeah, differentiating between the hip arthritis and or something like a bursitis or a labral tear, you start getting into these things like you said that have a lot of overlap, and then you start really having to tease out with diagnostic skills, and then getting into
Yeah.
the various types of imaging. Now, I was under the impression that diagnostic ultrasound was the gold standard for hernias, but you use
It's
MRI and CT as well.
Right. They're all used for different things, and ultrasound is evolving. It's our least invasive imaging modality because of the lack of radiation associated with it.
Sure.
And I can do it in my office, and I can use it to size certain hernias and do some planning for it. But for very small hernias, especially in young, fit, athletic people, if we don't see what's coming out of the hernia is a hole in the muscular abdominal wall, and if we don't see what's coming out, then we often won't see the hernia. So ultrasound is not perfect either. CAT scan is used for diagnosis and also for planning purposes, and then the MRI is used mostly to look for other causes of pain that may be orthopedic related. It's much better to look at the bones and the hip joints as for looking at what else this might be.
Interesting. I'm super curious just because I'm not in your world on any level. When you say planning purposes,
Right.
you mean that you're actually coming up with a specific surgical plan prior to that patient coming in? So you're knowing where all the anatomical structures are and where you're going to make your incisions. Is that what you mean?
Yes, very good. Yeah, very interesting. You think, yeah, we look like when we're dealing with these things called ventral hernias. Okay, inguinal hernias, we don't need that much imaging. If we can feel an inguinal or femoral hernia, a groin hernia with our hand, there's sometimes, but rarely, a reason to do anything else, and we can schedule a different type of surgery to customize it. But to talk about what's called ventral hernias, ventral incisional hernias, hernias of the abdomen, of the abdominal wall that come from previous surgeries where the muscle opens up and there's a hole. The CAT scan we use for planning purposes to look at the size of the hole, to look how big the rectus muscles are, to look how healthy they are. Are they thick? Are they thin? To see what your oblique muscles look like. Are we missing anything else on the inside? And then based on that data, I'll be picking it. That will help me decide, am I going to do this robotically? Am I going to do this, laparoscopically? Am I going to do this robotically, extraperitoneal? These, just a lot of words that, yes, though that data helps me decide what's going to be the most efficient, safest, least painful way to fix this person.
That's super interesting. One of the reasons why I really wanted to talk to you is because you have this specialty in repairing, for lack of a better term, hernia surgeries that have gone bad.
Yeah, it's not, there are excellent surgeons all over the world, all over the country, and sometimes things aren't perfect. And especially when it involves young, healthy, active, body-sensitive people, it's a discomfort issue. And for all people, it could be, rarely a life-threatening problem, disfiguring problem. But yes, there's a lot of, historically, there have been a lot of complications from hernia surgery resulting in early recurrence of the hernia or infection or pain or discomfort. And that's when I say young, healthy people, like those are the people that just don't tolerate that. And then they need something to undo that surgery, to revise that surgery, to let them get on with their lives, which sometimes is removing the mesh or fixing the hernia in a different way. So yes, that's a big part of my practice.
One of the things that I'm really curious about, because I was reading, long-term studies that were like looking at people having the surgery and then tracking them for 15 years afterwards, and the success rates in general for different types of hernia repairs seem very, very high. So when you say historically there's this issue with complications, why is that?
Well, in the history of surgery and surgery education, there's a lot of big decisions that needed to be made, on an academic level, how to train a surgeon, what happens most commonly, and so on, and what types of specialties a surgeon's going to go into. So the history of hernia surgery is that hernias are not quite as dramatic as brain surgery or heart surgery, or cancer surgery. So they didn't necessarily attract a lot of effort for specialization and training, that they were often historically left to the least experienced people to fix. but as I go on with this, I want to just say that this is really changing. Now, academically across the country, there are brilliant young surgeons that are hernia specialists. I've been a hernia specialist for over 20 years, and there are now really brilliant young people that are heads of departments of surgery or major instructors at universities that are hernia and abdominal wall specialists. So it's changing.
Absolutely.
It is recognized. And these young people on an academic level are really working to change this history and make it so the average community surgeon does hernia surgery better than they ever did it 20 years ago.
Absolutely.
So I think the future is strong for hernia surgery, but it's just changing now. Yes.
Yeah, well, that's great. I mean, it's to the credit of the profession, right? That you're learning and improving as you go, which is every profession should be.
Right.
So when people think about hernia repair, Dr. Yunis, the image that comes to most people's minds is a mesh surgery. And in talking to you in our conversation off camera, I learned some things about some options that don't involve a mesh. When I was reading about them, following your suggestion, I found that the success rates and the rates of complications between the two were very comparable. But can you talk a little bit about what are the different options for people who have hernia, and in what case might which option be a better fit?
Yeah, that's a great question. The mesh related issues are most commonly the problems historically have been pain and discomfort.
Mhm.
And in expert hands with certain techniques, the incidence is actually very low.
Mhm.
So to really answer your question first, yes, has been an evolution of two major types of non-mesh techniques for inguinal and groin hernia repair, which are the de Sarda repair and the Schuldeis repair. And those operations are very effective. The Schuldeis repair has a history over 50 years at an amazing hernia center just outside of Toronto at the Schuldeis Clinic. And there's a brilliant group of surgeons there that are heavily, they all work together as a team and share information, and they're getting excellent results for these non-mesh techniques. That's my favorite non-mesh technique as well. I also do a lot of de Sarda repairs, depending on what I find. Dr. Mohan de Sarda from India designed an elegant operation using the patient's own fascia. I find it very appropriate for certain types of inguinal hernias. So when these operations are performed without mesh, you eliminate the risk of mesh-related complications right from the get-go because you're not having the mesh.
Mm-hmm.
So that's what's really fantastic about it. There's a big learning curve to getting good at these surgeries, both in terms of kind of exposing it safely without injuring the tissue and then reconstructing for the repair. But even in expert hands, we think the recurrence rate of the inguinal hernia is higher, a little bit at least, among non-mesh techniques. The Schuldeis Clinic claims a risk of recurrence of less than 1%, as does Dr. de Sarda. I think it's less than 5%, nationally. But it's not like they're all going to recur. So it's a very good option as an initial option to have a non-mesh repair. But I just want to also, but your question was very broad. And then I want to just speak in terms of what the convention of, in the United States right now, among these brilliant young academic surgeons, the hottest technique that is used really that's recommended is a robotic inguinal hernia repair. And that's a big part of my practice. That always inherently involves the use of mesh, but with a robotic inguinal hernia repair done by an expert, putting the mesh where it needs to be behind the muscular abdominal wall, but in a layer, which is what we call behind the peritoneum, extraperitoneal. The risk of mesh-related complications when that operation is done perfectly is close to zero also. It's not zero because we're still putting mesh in. So that is the standard what that's going to be the most common way going forward is robotic inguinal hernia repair, but there's literally 7 common techniques all over the world, depending on where you are, depending on how you're trained, of very different operations used to treat the same groin inguinal hernia. 7 different ways.
Okay. And like I said, in reading the most of what I could find in the literature, even the long-term studies, the success rates were extremely high, the complication rates were extremely low. The one thing that I would like you to explain, just because the audience are not primarily abdominal wall surgeons, is how the mesh actually works. Is the idea that we're putting a lattice over the area of weakened tissue and we're allowing scar tissue to infuse and wind its way through that structure?
Yoni, you got it exactly correct. That is right. The materials of mesh have obviously evolved over almost 50 years now. So it's typically a lightweight plastic like polypropylene, which is woven. And it's relatively inert. You could read differently, but there's a long history of safety with it when it's put in perfectly. And the body sees this woven plastic and sends types of scar tissue, granulation tissue initially on a cellular level through the hole. So now we use meshes we've learned with bigger porosity, larger holes, right? Since it's woven, there's holes between the fibers. So now it's more popular to use mesh with larger holes, which we find is better tolerated. Maybe, we think in a lot of studies that there's less pain with these macro porous meshes. So the body sees it, it grows tissue between it, holds it in, makes it stronger than it was before.
Interesting. Is there any option, Dr. Yunis, for a material that would absorb back into the body after the scar was formed?
It is happening right now, and the data of what it means long term, is it as good as no mesh at all, or is it better than no mesh? Those options exist. There are 2 or 3 synthetic absorbable materials. And one of them I'm involved in a large clinical trial for, made by the company Gore. And they have a material called Enform, and this is something that over 6 to 9 months will be completely absorbed. But in the beginning, the fibrous appearance of it, clearly with previous models of the same chemical compound, has shown to likely be more beneficial than nothing at all. Yes, it is an option.
Interesting. I want to geek out for a second, if it's okay with you, because I'm fascinated by the robotic assisted surgery. Can you explain that a little bit? Because I still imagine it takes a skilled surgeon's hands to be operating the robot. So how is it superior to just being in there with your hands?
That, it's let's just say right now, the robotic surgery has been a gift to me, let alone my patients.
Okay.
And I would just give you a little, you do have to have good hands as a surgeon. You also have to have the understanding of the anatomy as a surgeon, but you also, it takes 3 or 4 years or over 500 cases at least to get really facile with playing this best video game that's ever been made, basically. So it's, and a lot of us, so including myself, when I say it's been a gift to me and my patients, a lot of surgeons like me were reluctant to move from laparoscopic surgery to robotic surgery because we were getting really good results. Laparoscopic surgery is where we hold instruments by hand, and robotic, I really need to explain it, is where we have, robotic arms controlling, much more complicated instruments. But there's a resistance among a lot of surgeons to make this step. And why is it so unbelievable? After the learning curve and so on, because the camera is ultra high definition 3D. When we do laparoscopic surgery, we're holding instruments like this. We're all looking at a high definition video monitor with a camera that someone has inside. And we have instruments going in and out of the patient, scissors, clamps, needle holders, whatever we need. And those are kind of what we call straight sticks, where they have little grasping device where at the end there's a scissor or a clamp or a needle holder. But now we make the same tiny little cuts, maybe a ½ inch, with tubes that go in that connect the outside world into you. I get that in, that's a skill unto itself. My assistant is then at the table, and we hook up that unbelievable high definition 3D camera through one of them, and then we have 2 or 3 other arms where we put scissors, clamps, needle holders, whatever we want, and they're attached to these robotic arms. And those robotic arms aren't just pulling something around, they also have these pulleys that at the end of these instruments, it's wristed. So it's like your hands are inside of this patient.
Wow.
And those arms, after they're attached, are connected to obviously a big computer system. And I've walked, into the corner of the room, 8 feet away, 15 feet away, and I'm sitting down at the best, game console you've ever sat at. Like it's a 3D virtual reality thing, where I'm immersed in a 3D situation with both eyes. My hands are comfortably resting on a little table with very delicate hand controls with clutches so that you can account for moving long and short distances to kind of get things back to the middle. So you're sitting comfortably. And then on the ground, there's 8 foot pedals and different combinations of little things we do with our hand and little other buttons that we have. I'm at the point now, as most advanced robotic surgeons are, where I can't even tell you how I'm really doing it, but I'm sitting there. And then if you look at the table, there's things moving in and out of the patient. And then my assistant is telling stories, to everyone else in the room. And I'm basically, doing, the surgery. And I'm controlling everything myself. I don't need an assistant other than to change a scissor to a clamp. So the reason why it's better is because I can control that camera better than an assistant, which we did in laparoscopic, and the camera can be this close and it's higher resolution. So we're seeing things that we've never saw laparoscopically. Wow. Nerves. It's almost like we see what we call histology with this. It's amazing.
Wow.
And then my instruments I can sew better than than you can, even though I can sew laparoscopically. We all got good at that. We can sew very accurately, like on the ceiling or a very tight space. It's just fantastic.
That's so cool. We don't have flying cars, but that sounds like some Buck Rogers technology.
It's really changed the game. It's so fantastic. Now, not every surgery should be done that way. Some of my open non-meshing on hernia repairs are in some ways less invasive because we're not going in the patient. So not every surgery should be robotic, but what a gift it is for these very complicated ventral hernias.
Sure. Yeah. One more tool in the tool belt, right?
Yeah.
Talk to me a little bit about what you just said. Not every hernia should be repaired that way. In what instances are these non-mesh techniques like Scholdice and Desarda preferable? Is there an age range or a type of patient where your mind goes to the non-mesh, or how does that work inside of your decision making?
Well, with the awareness that a lot of people have through social media and the internet, and people want to be proactive about their health, like with programs like that you have, there's a lot of awareness that mesh potentially can cause problems. So a lot of it is self-driven, that people just say, what can you do? Can you do something without mesh? So a lot of it is that.
Okay.
But at the same time, if we look at, and we're talking again mostly about inguinal hernias where, mesh is a problem, and umbilical hernias. And so certain patients that are thin, muscular, younger people tend to have more pain with certain hernia surgeries. And we just know that statistically. And so there's a category of person like that I will often want to do their surgery without mesh, because my risk of problems in the future is not, I'm not so worried. If their hernia came back, that's not as important as if for the next 3 years they're still having pain in their groin. That's what we don't want. So it's younger people, active body sensitive people. Those are the people that I tend to want to do a non-mesh technique on. Is
there a difference, Dr. Yunis, in the recovery in terms of how long it takes to get back to activity between the mesh and the non-mesh?
The recovery really is about the same, but it's just a different experience. And I might protect, or when you have a non-mesh technique, because I think because there's no material there and there's this higher potential maybe for the hernia to come back, which is true. It's not a high percentage. I tend to restrict or tell people to not be stressing the area of the hernia quite as much after the surgery for maybe a couple of months than I would if I did a robotic or laparoscopic repair with mesh. Then probably after a few weeks, the restrictions would be unlimited. But certainly after 3 months, there's no restrictions no matter what you do, or 2 months. But the recovery is, the recovery is based on, as a surgeon, we also want to get good at what can we do when we do these surgeries to make it not hurt, to avoid any other problem. There's all these subtleties when we do surgery. So I'm at the point now where my laparoscopic, my non-mesh hernia repairs and my robotic repairs have a very similar experience of recovery, to answer your question. Yeah.
Nice. The one other thing that I wanted you to touch on is unnecessary surgery is something that we want to avoid in all instances. Now, you mentioned a few types of hernias that repair themselves given enough time. In what instances is the surgery the option? And in the case of inguinal hernia, for example, it seems to be really the only option. Like I said, I've worked with some of these patients, and rehabilitation from strengthening intrinsic support structures, it doesn't work.
Yeah.
And so in what instances should the person really be looking to surgery, and in what instances can they kind of not go that direction?
Well, with inguinal hernias, they never go away. They really don't. They don't, the natural history of an inguinal groin hernia is unpredictable for a given individual. There are individuals that can have an inguinal hernia and it's painless, and they can live with that hernia their whole life, and they may occasionally get some discomfort, and they're never going to have an emergency from a hernia. And there's never a problem. And then there's people that get a hernia and it gets worse right away. So it's not that you have to have surgery if you have an inguinal hernia, but if you want your hernia fixed, it's the only option. It will never go away on its own.
So it's interesting because we see the same types of things with, say, rotator cuff tears, meniscus tears, and disc bulges, where if you grab a handful of people at random off the street who don't even have pain and you give them an imaging study, you'll find these problems in roughly 50% of the population. So is it an idea where, like, you just let sleeping dogs lie? Like, if it's not impacting your life, you don't do anything for it?
Great question. So, because one thing we haven't talked about today is the fact that inguinal hernias, more than most hernias, have some risk of an emergency associated with them. So that's why, from a personal philosophical basis, some people want to get their hernia fixed even when it's painless.
Okay.
Because they want to avoid the risk of this emergency. The emergency being something we call incarceration and strangulation, where the hernia is the hole and something's moving in and out of the hole, and for many different reasons it all of a sudden gets stuck. Sometimes when it gets stuck, it's meaningless. But if the intestine gets stuck and it's tight, it's like somebody squeezing your neck, strangulating the contents, where strangulation of the neck will kill you because of loss of blood flow to the brain. The strangulation of the tissue of the bowel, in rare circumstances, people can die, The incidence of death from young, healthy people from inguinal hernia is exceedingly low. But the potential for emergency is, maybe we think demographically maybe 4 or 5% annually per person per year is some number that's been come up from looking at a lot of statistics. But the emergency in a young, healthy person, to be clear, is almost never fatal. But isn't it inconvenient to have to go to the emergency room, have an incarcerated hernia, and miss your trip the next day or miss the meetings, it's never a good time to have an emergency and then need an emergency surgery. So that's a reason why people choose to fix it too. It doesn't have to be that way, because some people, you can live with your hernia if you can tolerate it. And I'm saying the chance of you dying from it is exceedingly low. And some people don't mind and can show many years without a problem.
Mm-hmm.
That makes sense?
Yeah, very, very interesting, and an excellent point. The other thing that I read about, speaking of the emergency situations, was associated with the femoral hernias.
Yeah.
Where those were considered, and correct me if I'm wrong, the most dangerous type of hernia. Can you talk about why that is?
Yeah, that's a historical suggestion. As an experienced hernia specialist, that I don't think that is true anymore.
Okay.
That's what we thought. And the reason why we thought that is a femoral space where femoral hernias occur, right next to the femoral vein going into the leg, is a potential space called the femoral canal.
Mm-hmm.
And it's small, and when something goes in and out of it, it has a higher chance of getting stuck. That's just a common sense thing.
Mm-hmm.
But it's typically fat, and I think it's an exaggeration. So I don't think it's as dangerous as historically thought. No.
So the idea was, if the tissue got into that region, it would somehow affect circulation.
To circulation to what it's in it. So if it's your bowel, is what's dangerous. If your small intestine gets stuck in the hole,
okay,
and it's getting squeezed,
okay,
the blood supply of the intestine that's squeezed, like on the outside, it can die, just like your brain would die from here.
sure.
So that's the fear. And I'm saying really the incidence of it, like, there are emergency hernias in every emergency room all over the country every day, but rarely is it something where the person's about to die, even though, that potential exists.
Interesting. Absolutely fascinating. I'm blown away by it. You mentioned one other thing that it was in a previous conversation that we had. The shape of the mesh. You were talking about using different shapes. Now, was that a part of your planning process going into the surgery with the person, that's based on their anatomy? Or how do you decide what shape you're going to use?
Well, when I use mesh in ventral hernia repair, which is now typically robotic technology, almost every ventral hernia repair that I'm doing is robotic. We use a very lightweight woven mesh, and it's kind of the least of the surgery, and we're creating a shape to fit in the area that we exposed. But I think in our conversation, what we were talking about is that in the inguinal region, again, with these groin surgeries, there are historically different shapes of mesh that have a dimensionality to them. Like one of them looks like a little badminton birdie. Some of them are at least three-dimensional objects to have a mesh on one side and another. And when used properly, there are millions of people that have benefited from these. So and they're on the market. But different shapes of the mesh, when they're not put in perfectly correctly in people that are sensitive, that they're going to feel it. Not that we could predict who that person always is, that these different shapes of mesh in the groin are implicated in higher risk of that person complaining, is what I was talking about. In inguinal hernia.
Okay.
But in ventral hernia, right, all we use are these flat meshes of different materials, and then the shape is just about fitting into the space that we dissected.
Super interesting.
And to be more clear about that, like a lot of people think if we're doing a mesh-based hernia repair, especially if we just look at robotic surgery and what it's done for ventral hernias, those are the big hernias of the abdomen, in the front of the abdomen from what we call laparotomies, where someone went in to fix an aneurysm or take a colon cancer out. I could be working on this patient for 2.5 hours of exposing robotically, dividing certain attachments, sewing this layer, sewing that layer, and then it's only the last 5 minutes of a 2.5-hour surgery that we roll up this lightweight mesh, send it in, lay it out, and maybe sometimes don't even sew it. Maybe we spray some biological glue to keep it in place. So it's really become like the least of the surgery, but we think it's necessary for strengthening for the long term to prevent recurrence of the hernia. There's a lot of data to support that.
Interesting. With a lot of medical problems, what I'm typically looking for the final frontier, it involves prevention. Now, it sounds like with what's going on with hernia, that may never be an option. So what is the final frontier for hernia problems, this problem that's requiring 20 million surgeries a year? Is it this robotic assisted? Is it the non-mesh techniques? Is it more minimally invasive stuff? Where do you see this going in the next 20 years?
Well, there is prevention, though. That one thing that we haven't talked about, that there's prevention of these ventral incisional hernias, which is its own world.
Let's talk about that.
Right. So, when you have even robotic surgery makes little cuts, laparoscopic surgery makes tiny little cuts. And even through those cuts through the wall where we put these tubes in that send instruments or suture through, that even those openings over time, or where the surgeon, did a robotic prostate removal, and that cut might be a little bigger, or colon removal might be a little bigger, or a kidney removal, and they sew it back up, those areas that open up over time, there's work being done by surgeons to talk about what's the better sewing technique, what's the better material, how big the bites are when you sew of 2 millimeters, how far you move along. Many surgeons are working on prophylactic mesh, even prophylactic absorbable mesh, where that after you take the colon out in this situation, that this is a very high risk patient that's gonna get a hernia. And so after they do the surgery, they'll put in a type of mesh safely, not where they're thinking about how can we use this safely. So that's being worked on extensively to reduce the incidence of these ventral hernias. And then the management of these primary hernias, the kinds that were really born with the potential to get, we're just working on ways, as I say, there's a lot of brilliant young minds all over the country contributing to this, that we're just getting better at doing safer, less invasive ways to fix it with robotic, or I think non-mesh surgery is coming back as well. Yes.
That's awesome. You're a wealth of information. Thank you so much for making the time. Please tell everyone listening, if they would like to find out more about a hernia situation that they're dealing with, where can they find you?
Well, they can find me at my website, centerforherniarepair.com or dryunis.com. And we have a nice office that we're happy to talk to you through email or give you advice about maybe where to get care where you are. I'm in touch with a lot of experts all over the country. I don't have to be the surgeon, but I'm very interested in helping people see some of the experts that I know that may be closer to them.
That's awesome. Very generous of you. And your practice is located in Florida?
Sarasota, Florida.
Excellent. And I'll put contact information for Dr. Yunis in the description underneath this video.
Great.
Thank you so much for making the time. I really appreciate it.
Thank you so much. Great talking to you.
If you need more information on hernia repair, I encourage you to reach out to Dr. Yunis and his team at the Center for Hernia Repair in Sarasota, Florida. I'll put their contact information in the description under this video. Beyond that, I just want to thank you so much for watching. If you enjoyed the video, please hit that thumbs up button. And if you know anyone who's suffering with a hernia, make sure to share this important information with them. That's all for this week. See you next time.